Good evening, everyone. I'm Dr. Nishant Sharma. Welcome back. Welcome to another episode of this virtual discussion with Zydus, where we will be talking about the importance of breast cancer prognostic testing. As we know, October is a breast cancer awareness month, and we are here to understand through our experts the importance of early detection, the innovations in detections that we see. So, without further ado, allow me to please welcome all my panelists. We have with us Dr. Murali Voonna, Managing Director and Chief Surgical Oncologist at Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam. Good evening, Doctor. Thank you for joining. We have with us Dr. R.K. Deshpande, Surgical Oncologist, Executive Chairman, Asian Cancer Institute, ACI, Cumballa Hill Hospital. Good evening, Dr. Deshpande. Thank you for joining.
Good evening. Thank you.
Thank you. We have with us Dimple Parmar, co-founder and CEO, Zen Onco.
It's not allowing me.
Hi, ma'am.
Hi, good evening.
Thank you for joining.
Thank
We
you.
have Dr. Mounika Boppana, consultant medical oncologist, KIMS Hospital, Hyderabad.
I think.
Hi, good
Hi,
evening, Dr.
good
Mounika.
evening, everyone. Good evening, everyone.
And we are having Dr. Tanay Shah, consultant surgical oncology, SGG Hospital, Ahmedabad. Good evening, Dr. Shah.
Hello, everyone.
Joining.
Good evening.
And allow me to introduce our moderator for this evening, Dr. Rohit Kumar, consultant surgical oncology, Aster CMI, Bengaluru. Good evening, Dr. Rohit.
Namaskar. Good evening,
It's a
everybody.
pleasure. It's a pleasure. So, Dr. Mohit, over to you. Thank you.
Yeah. So, good evening, one and all. We all know that October is a breast cancer month, and prognostic testing in breast cancer is of utmost importance for all our patients. This topic holds particular significance not only in the field of oncology but for the patients and their families as well. So, the prognostic testing, as such, it helps us in tailoring the treatment, improving survival, minimizing over treatment and under treatment. What is important in oncology is to do what is required for the patients and not to overdo or underdo things. And more than that, in a resource constrained country like ours, it will help us in resource allocation, and also it helps in using the resources optimally. So we have a great panel with us today who will be shedding the light on the importance of breast cancer prognostic testing, which is a topic that we're going to talk today. With no delay, I'll start my first question. My first question is to Dr. Murali Krishna. So, what do you think are the key prognostic factors that oncologists consider when evaluating breast cancer patients? And how does hormone positive breast cancer differ from other types of breast cancer?
Yeah, thank you for the opportunity and good evening to all of you, friends. And basically, we are coming to the basics of breast cancer management. Like all of us know, that the prognostication and prediction is very, very important in the management of breast cancer. So there is a lot of overlap in the prognostication and prediction in the breast cancer over the years. And in general, the prognostic factors, when we start looking at the patient, we immediately see whether the biopsy report shows in favorable histology or not. Then what is the grade of the tumor or Nottingham score? And as you know, the TNM staging, the tumor size, nodal status, and metastatic status. And is there any duct carcinoma in situ is there or not, which may change the management lines. And if the surgery is already done, margin status also is very, very important. And in histopathology, the lymphovascular invasion also is very, very important if you go through the deeper into the histopathology. But the most important prognostic and predictive markers, generally what we talk and use in the regular clinical practice, are the hormone receptor status, like estrogen receptor status, progesterone receptor status, and peritoneous amplification, that's evidence of growth factor amplification, and the proliferative index like Ki67. And with the advent of the concept neoadjuvant chemotherapy, both in and locally advanced breast cancers and triple negative breast cancers, the response to chemotherapy in the post chemotherapy surgical pathology report also is very, very important. So coming to the latest prognosis and prediction practice the gene panel. The various microarray gene panels are available here. We used to read a lot, but never used to practice of advising Oncotype DX, Memaprint, and Prosina, and other tests which are actually done abroad and very very expensive. In India, logistically, the chemotherapy would cost less than the test cost itself. So we never used to advise in regular local practice, but with the advent of the Indian test, to actually we are advising more number of patients for this gene panel like CanAssist, and the coming to the other prognostic markers like PDL1 in triple negative breast cancer also, is also one of the prognostic marker, and all these things we are using in early breast cancer. In advanced breast cancer, stage 4 breast cancer, sometimes we are using PIK3 mutation status in hormone receptor positive patients, BRCA mutation, somatic genetic mutation status. These are the two important things which we are asking for a prognostication in a stage 4 patients. So
Okay,
basically,
that's
these are the list of prognostic and predictive marks which generally we use. All of them we are using in all of these factors we are using in our regular practice.
that's a great comprehensive answer for whatever you have given, sir. That's it's almost compromising all the prognostic factors for both early breast cancer and advanced breast cancer. That was a very apt reply to whatever you have given now. Having known the risk factors or the prognostic factors that is important in managing breast cancer, now let us look and move to our next question. Our next question is to Raman Deshpande sir, who has been a guiding light and a mentor to most of us, and he's been like a a guiding source for all of us growing up. Sir, my question to you will be: how has the prognostic testing evolved over the years, and what advancements have significantly impacted treatment decisions?
Thank you, Rohit. At the outset, I'm very thankful for inviting me on this August panel. And I'm sure this is working out to be a very, very good get together for everybody. Now, Dr. Murali has actually laid out a very nice pathway for discussion, and he mentioned the various factors which are really important. Now, if you really go back and find out the history, in the early, like almost like 40, 50 years back, it was only the pathological or the morphological testing which was supposed to be very important. So you saw the size of the tumor, you saw the grade of the tumor, you saw whether, and then came the most important prognostic factor, which is the lymph nodal involvement. So these were the things which were thought to be very important. In the 1980s, actually, things started moving towards molecular diagnosis. So the hormone receptors started coming. People started realizing that if you give the tamoxifen therapy, actually patients will do better, and particularly if they're ER positive. In case of ER negative, that was not a risk. So all this research kept on coming, and eventually now today, what is happening is we are dividing the breast cancer into 4 different types: the luminal A, luminal B, then the basal type of this thing, and the HER2 positive, the group 3 HER2 positive. So when you have estrogen and progesterone receptor positive, but HER2 negative, then it is a luminal A. By and large, these patients do very well. They are probably the best prognostic group. Their survivals are almost up to 95% in the all comers kind of a group. When you look at the luminal B, then estrogen is positive, progesterone is negative, and and HER2 is positive. Now they do not do as well as the luminal A, but and they actually are helped by chemotherapy and partly by the Herceptin therapy. Then the third group is basically the Herceptin positive, but ER and PR both are negative, and they are actually helped by chemotherapy and Herceptin therapy. The last one, the worst one, is the And these are actually helped by immunotherapy and
So can you hear us?
yeah, better. So this is how things have actually shaped up, and today we are in a far advanced position. Then the further thing is there are certain genetic patterns which actually help us identify the patients who are likely to do well and who are not likely to do well in hormone receptor positive patients, and in HER2 negative patients. And that is where, like what Dr. Murali said, you can actually have the genetic panels like the Oncotype DX, or even something closer home is the CanAssist type of a classification. And these will actually divide the patients clearly into people who will do better and people who will do worse. And then you can decide whether to choose aggressive treatments like chemotherapy, which have their own problems. There are distinct problems in giving chemotherapy. And if you can treat the patients only by hormonal, it is generally better. But you can't treat patients with hormonal if the hormone receptors are negative. So this is how things have evolved over a period of time.
Yes. Thank you, sir. As always, detailed and nice reply. Uh, Good. Now, having understood that prognostic testing is very much important in one of the close set of patients, that is the luminal A group of patients, or the luminal B, where we have ERPR positive, HER2 is negative, and the lymph nodes being positive or negative early breast cancers. So we are looking at a very selective group of patients for whom this is going to make a lot of difference. So now I'll move my next question to Dr. Mounika Boppana, who is a consultant medical oncologist at KIMS Hospital, Hyderabad. Madam, can you please explain the role of genetic testing in breast cancer prognosis and how it influences treatment strategies?
Yeah, so the hormone positive node negative breast cancer, which is the early breast cancer, the survival rates are so good, the 5 year survival rates being more than 90-95%. So in oncology, generally the dictum is that once we've achieved such excellent survival rates for any particular malignancy, we try to see if we can tone down the therapy in some of them, who would do really very good according to any predictive factors which we take into consideration. And this kind of an evolution we see for diseases like Hodgkin's lymphoma, where the survival rates are very good, and also in many of the pediatric malignancies like acute lymphoblastic leukemia, the 5 year 10 year survival rates are so good that now we are trying to go for a risk adapted therapy where we give intense treatments only for the high risk individuals, and we give a mellowed down treatment for the low risk patients. So a similar pattern of evolution we have seen even for hormone positive early breast cancer, node negative breast cancer. So earlier, a few years ago, it was mainly clinical factors which we were taking into consideration, like the menopausal status, the age of the patient, the grade of the tumor, as it was highlighted by my senior colleagues in the last 10-15 minutes, and also node positivity, whether lymphovascular emboli, perineural invasion, whether it's present or not. So based on all these factors, based on clinical factors, we used to decide on the adjuvant therapy. Now it has moved from the clinical factors, because earlier we were offering adjuvant chemotherapy for every woman who was operated, even if it's hormone positive, HER2 negative breast cancer, even if it's node negative, every patient was being offered chemotherapy. Their survivals were very good. So we wanted to see whether we can skip chemotherapy in some of these women. We might be over treating a good chunk of these women and unnecessarily exposing them to the toxicity of chemotherapy, potentially long lasting toxicities like the cardiotoxicity of anthracyclines. We want to avoid in them. So we want to identify those really high risk patients and give chemotherapy only to them. Now, the problem here is that based on the conventional, the traditional factors which are used for risk stratification or to brand a patient, a disease as a high risk disease, high risk of recurrence, the traditional factors which I have listed a little while ago, by using them alone, we might be missing some women who are still at a high risk of recurrence, even if everything is looking good. So that happens maybe, I can say, in about 10 to 12% of the women where all the factors look good, node negative, very small tumor, postmenopausal, grade 1 tumor, and there is no lymphovascular emboli, and we put her only on hormone therapy, and still we see that about 10% of such women still experience a recurrence few years down the line. It means there's something else beyond all these traditional factors which dictates the biological behavior of the tumor and how high is the chance that this tumor would recur. So, with this in mind, they try to identify which are the genes, which are the factors which are responsible for the aggressiveness, the biological aggressiveness of a tumor and its chance of recurrence. And that's how the 21 gene assay, that is the Oncotype DX, had evolved. So this assay basically it looks at different genes, 21 genes. There are proliferation related genes like Ki67, STK15, BIRC5, CCNB1, MYBL2. Then there are metastasis related genes like MMP11 and CTSL2. HER2 related genes are there like GRB7 and HER2. Sex hormone related genes like the estrogen receptor gene, progesterone receptor gene, BCL2 and SCUB2, GSTM1, BAG1, CD68. These are all the genes which are looked at in Oncotype DX assay, which is a 21 gene assay. And then a score is given from 0 to 100. And earlier there was an intermediate risk category also, but now that has been removed. We only have a low risk and a high risk category. So this is how the prognostication of a patient has evolved over the last few years. And we need to understand the biology of the tumor because everything is about the genes nowadays. We have so many targeted therapies coming up which are targeting specific genes, specific molecular alterations in a tumor, not only in breast cancer, but so many other cancers. So molecular genetics is playing an increasingly important role nowadays. And so it's not just the traditional risk factors that we have to look at, but it's important to dig deeper into the cell, into the cancer cell, look at the genes which are regulating the biological behavior, that are dictating the biological behavior of the tumor, and an ideal assay in the current. So even Oncotype DX is, it's not that it's 100% right all the time. There can be, we have seen cases where it has given as a high risk score, but the patient still refused chemotherapy. So she's been put only on an endocrine therapy and still they're doing fine, even 5 years, 6 years down the line. Also, they are still doing fine, touch wood, without any recurrence. Similarly, we have seen patients where Oncotype DX has given a low risk of recurrence. So chemotherapy was skipped. And a few years later, the patient has had a recurrence. So both ways, it's not like the specificity can be 100% or accuracy can be 100% for any particular investigation. So what we need to look at is we need to understand it's evolving. We need to understand the genetic basis of this biologic behavior. It is evolving, continually evolving. We are learning more. We are still in a learning phase. Many assays which are better than this might come up in the future. And an ideal test, a prognostic, a test which is prognostic and which would risk stratify a patient into low risk or high risk of recurrence, should include all the genes which would dictate the biologic behavior of the tumor.
Great. Thank you, ma'am. This leads me to, quote one of the greatest quotes that is given by Blake KD, who told that, biology is king. In surgical oncology, or the fundamentals of oncology, the biology is the king. Selection is queen. Technical maneuvers are the prince and princesses. Occasionally, the prince and princesses try to overthrow the powerful forces of the king and the queen, but only it's a temporary victory. And ultimately, it is all about the biology and the selection of patient that actually matters in the outcome of the patient that they're managing. So now, having listened to the prognostic test that we are doing here, now I would move my next question to Dr. Tanay to ask him, can you explain the scientific basis beyond CanAssist's ability to predict the 5-year risk of recurrence in hormone-positive breast cancer patients? So we'll now be discussing a brief about CanAssist, which is a prognostic testing in breast cancer.
Good evening, everyone. First of all, I would like to thank the Zydus team for having involved me in this panel involving such an esteemed faculty members from all over the country. So, to answer Dr. Rohit's question, yes, we know that now it is the biology which is, dictating the terms in terms of prognosticating the disease over anatomy, and the breast probably by far is the most researched cancer worldwide. And as we deeply understand the disease, our treatment is getting more and more focused. And as Dr. Mounika also said, that for luminal A and selected luminal B patients who are HER2 negative, we are probably over treating a chunk of them by chemotherapy. So, CanAssist breast is a very good prognostic marker, which not only involves the various genes, but it also involves the clinical parameters, the tumor parameters as well. So, namely the tumor size, nodal status, as well as the tumor grade, which I think are not involved in any of the Oncotype DX or EndoPredict. Apart from that, the genes which are more important, 5 genes are involved, and they are studied by simpler method, which is IHC, which is more objective assessment. So these genes are ABCC4 and 11. So these genes are basically coding for the insensitivity to the anti-tumor growth signals. Another is CD44, which basically codes for limitless growth potential of the tumor cells. And the other ones are the N-cadherin and pan-cadherin, which are basically involved in tumor invasion and metastasis. So taking into consideration all these genetic factors as well as the clinical parameters, it is basically a more objective assessment, and it gives us a cutoff score of 15.5. So below which we do not require to treat luminal A and selected luminal B patients with chemotherapy. They can do very well with endocrine therapy alone. And it also gives us a 10-year recurrence risk with endocrine therapy alone in such patients. And this can hold true for early breast cancer T1, T2, N0, or up to N1 also.
Great. Thank you, Tanay, for laying out the importance of CanAssist. So now, having heard from the clinicians as such, let us now hear the perspective of someone who actually matters a lot, who is at the receiving end and who knows what it matters when you have to be at the receiver's end, how you can take it, and how actually you can process all these things. I have Mrs. Dimple Parmar with me, who is co-founder and CEO of Zen Onco, who herself has gone through certain things in her life which has led to this formation of this Zen Onco, which is a complete integrative oncology platform. Mrs. Dimple Parmar, can you explain to me how do you approach the communication of prognostic testing results with patients and their families? And how much does it impact in shared decision making?
Right. Thanks you so much for having me here on this platform today. Thanks to Zydus and Voice of Healthcare for inviting on such an esteemed platform with some of the renowned oncologists to speak on the prognostic testing and the breast cancer. I was a caregiver 7 years back where I lost my husband to cancer, and that's what motivated me to start zenonco.io on the concept of integrative oncology, where our mission is to make integrative cancer care more accessible and also improving quality of life, managing side effects, and extending life wherever it's possible. When we talk about prognostic testing for breast cancer, many times when patients come to us, depending upon which strata they're coming from, they might not be even aware of what is their ER, PR, and HER2 status. So it's important to explain them first what does that mean and what their report says in terms of what their markers are and in terms of the hormone receptors. So when we explain them, we have to explain them what is triple negative and what is ER, PR, HER2 status, and how does it help them in understanding the treatment plan that oncologists are recommending. So we do have cancer coaches who explain them in terms of what does it mean, and how it impacts their treatment at the same time. So at the same time, patient do ask questions around how do we integrate holistic care or integrative oncology care based on what is their status are. So a holistic approach, prognostic test definitely helps tailor not just medical treatment but also lifestyle changes, their dietary plans, their emotional support, their physical support, and pain management, which is truly integrating all aspects of oncology care. Evidence gathered from prognostic tests ensures that all the elements of the care plan, from chemotherapy to the stress management, are in sync and aim for the optimal patient outcome, because that's what we all aim for. At Zenonco, what we try to do is to integrating complementary care in the medical treatment, chemotherapy, surgery, radiation, targeted immunotherapy, so that we can look at the best clinical outcome for the patient, at the same time ensuring that their quality of life improves and clinical outcome improves. When we talk about certain supplements and ER status, research suggests that certain supplements may interact with estrogen receptors and potentially stimulate the growth of ER positive cancer cells. Therefore, it is often recommended for individuals with ER positive breast cancer to be conscious of the supplements that they are taking. Many times, patients come to us with different kind of supplements or different kind of dietary preferences that they have, and then we guide them based on their prognostic testing results, what they can go for, what they should avoid when they are on the chemotherapy, on the treatment plan. When we talk about soy isoflavones, these are phytoestrogens. They may mimic estrogen in the body. For ER positive, the use of soy supplements may be controversial. While patients say that they should take soy when they are taking treatment, it really depends on what are their prognostic test results says. When we talk about flax seeds, rich in lignans, another type of phytoestrogen, the recommendation for flaxseed also varies based on the ER status. So food that are rich in phytoestrogen like soy products, certain nuts may need to consume cautiously if patients have this type of ER positive. When we talk about dairy products, some studies suggest a link between high fat dairy products and worse outcomes for ER positive breast cancer. So it's very interesting to know that not just medical treatment but also the complementary and the integrative care may change based on what their markers are. When we talk about certain emotional aspects, which is very, very important when we work with cancer patients, and also especially women with breast cancer, they go through a lot of emotional trauma and psychological changes because of their physiological changes in the body. So hormone therapy like tamoxifen or for ER/PR positive cancer can have emotional side effects such as mood swings for women. So emotional counseling should be geared to address those specific issues. Anxiety management for HER2 positive cancer, it can be more aggressive, which may generate additional anxiety for women. Specific emotional well-being strategies can be devised based on what their status are. And knowing the hormone receptor status allows for more personalized emotional and psychological support. For example, mindful techniques may be especially useful for patients undergoing targeted therapy for HER2 positive cancers. We usually recommend this to everybody, but for these special type of cancer types and status, it's important that they go for certain, which is already evidence backed, and the studies are done on this. And when it comes to pain management, which is integral part
Yeah,
of the
Mrs. Dimple, yeah, that's great. You've analyzed about the emotional aspect and the things that were very much looking into it. Now we'll just move into the other consequences of the prognostic testing that we're going on. I would move my question to Dr. Deshpande, sir. So, can you discuss the role of healthcare providers in recommending and interpreting the prognostic test results for their patients?
Hello.
Hello, sir. Can you hear me?
Yeah, I could not hear your question too well.
Yeah, I'll repeat the question, sir. Can you hear me now?
Yeah.
Yeah. So, can you please discuss the role of healthcare providers in recommending and interpreting the prognostic test results for their patients?
Okay. Now, see, the prognostic factors are required for actually for the by the patient also, by the relatives also, and by the treating doctor who brings the patient also. So there are three basically distinct people who are very important. They would like to know what exactly is the primary treatment, what exactly is the further treatment, what exactly is the ultimate prognosis and likelihood of recurrences. So, from that point of view, one is the anatomical, the staging itself, the TNM staging, and the histopathological, the grading of the tumor. They help in a very preliminary kind of a way. But the real help, which will come, like what we discussed earlier, is when we start doing the molecular testing, the ERPR, HER2 receptors, and then what comes after that is that you could always have a small tumor, you will have a negative axilla, and you will have a hormone receptor positive with HER2 negative. How do you really treat these patients? There was a time when anything more than 1 centimeter was given chemotherapy. Now, chemotherapy is certainly not without its own problems. It has its own GI toxicity, its own cutaneous toxicity. It has problems of second malignancy also coming over a period of time because of that sheer effect of the chemotherapy. So then there came a necessity that no, you must actually differentiate how exactly the aggressive types are different. And I think Dr. Boppana actually very nicely she delineated how exactly genetic testing can help us. And like that, we have just as we have these excellent Oncotype DX, etc. We have our own Indian CanAssist, which uses 5 biomarkers and 3 clinical markers to differentiate the tumors into an aggressive tumor and relatively less aggressive tumor. There is a cutoff point of from 0 to 100. You have a cutoff point of about 15.5. Less than that, the benefit of aggressive therapy like chemotherapy does not really justify use of chemotherapy in those patients. So all these factors, when you put together, it's like almost like putting a in conventional very village language, it's like putting a kundali together and then prognosticating the what is going to likely to happen. Then you have other nomogram tables also, particularly from England. You have the nomogram tables with the likelihood of a recurrence in case of a given tumor with all the variables at hand. So with these kind of informations, you can actually prognosticate, and then the healthcare worker, the doctors can actually take help of all this and then treat the patient correctly and guide them appropriately.
Thank you, sir. Having stressed the importance of guiding our patients towards a better care. Now, I would like to ask Dr. Murali Krishna, how accessible is CanAssist testing, and are there any initiatives in place to make it more widely available to hormone-positive breast cancer patients?
Yeah. In the initial, now earlier we used to have a serious problem knowing that we can do a risk stratification and avoid chemotherapy in certain subset of women, but due to the cost of the test and inaccessibility due to the logistic reasons, etc., we used to give chemotherapy to those patients who are supposed to not to get the chemotherapy by doing at this prognostication. With the onset of availability of CanAssist in Indian market, though in the initial we are the first initial takers and users of one of the few centers to take taking seriously about this test and used it, but we faced a lot of sarcasm in among the professional groups also, because they were questioning about the validity and validation. And we know that as a doctor we know that how patients feel about chemotherapy. Particularly they are all worried about the loss of hair, fear about the side effects of the chemotherapy, long-term neurotoxicity, cardiotoxicity, and myelosuppression and related issues, and second malignancies, etc. We were very serious about advising these tests in particular patients. And as now it is available definitely at a cheaper price, particularly when compared to the cost of chemotherapy and to the cost of the morbidity and the treatment of those morbidities in the long term. Now we are counseling the patients upfront even before the surgery in all early breast cancers. And as a matter of fact, now it is mandatory that we have to do hormone receptor status before taking up the patient for surgery. It is mandatory in our hospital. So whenever there is an early breast cancer lady with the hormone receptor status positive and HER2 negative, we counsel them upfront. And for the chance of her not getting needing the chemotherapy is not getting the chemotherapy is about 50%. They'll be very happy, and they are welcoming the surgery, and that gives a very positive vibe to them because they are more worried about the chemotherapy side effects. So we made it as a part of our counseling sheet where all these patients will be counseled for the CanAssist test and the advantages of it. So, and it is available, and we made it as a part of the practice. And actually, we have used around in 45. We have till now, we have used around 45 patients we have tested, and 33 of them are negative, so they didn't receive any chemotherapy. So, yeah, now it is very commonly used test in our institution.
Yes, having done Mangalayana and Chandrayana, where we don't look at the cost. We Indians are known for innovations and at low cost considerations. CanAssist has certainly been a boom to most of our patients. So now looking ahead, Dr. Tanay, according to you, what potential advancements or enhancements you think are on the horizons of prognostic testings in breast cancer patients?
Yes, Rohit. So, to me, I mean, as we understand the disease deeper and deeper, we now have come to know that the approach of one size fitting all should no longer be followed. And as Deshpande sir said, that earlier we used to give chemotherapy to all patients having tumor size more than 1 centimeter. But then this practice we no longer can continue. I mean, giving chemo to all patients. So at times, this early stage luminal A, some luminal B patients, they may not be as sensitive to chemotherapy as TNBC cases, that we know very well. So this is one test which is now letting us know that which is the subset of patients who will be actually benefiting from chemotherapy, and what would be the prognostic. I mean, what would be the prognosis like at 10 years? So, if we dig more and more deep into this various prognostic markers and prognostic tests or the assays, the further advancements, what I can foresee is whether on one day, whether some test would be able to tell us that amongst those who are requiring chemotherapy, whether some of those patients can be spared of full course chemo, like all 8 cycles may not be required, and they can be given just they can get away with 4 cycle of TC or not. Some of the breast conservation surgeries, whether based on this prognostic assays, whether they can be spared of adjuvant radiation, or they can get away with APBI or not. Very recently, we have seen one trial from coming from Italy using baby-tam, that is tamoxifen 5 milligram, which has now told us that it is okay to treat DCIS and atypical ductal hyperplasia patients with 5 milligram tamoxifen for a period of 3 years, which is non-inferior to full course tamoxifen of 20 milligram OD for 5 years. So these are all the advancements we can foresee for future, particularly when we know that we are now, focusing the treatment more on the biology, and trying to curtail the treatment as and when possible, may it be surgery or systemic therapy. Rohit, I think your mic is muted.
Hello, sorry, can you hear me?
Yes, now we can hear you.
Yeah, sorry. Thank you, Tanay. Moving on to Dr. Mounika, how does breast cancer prognostic testing contribute to the overall cost effectiveness of breast cancer treatment in helping identifying patients and also avoiding chemotherapy?
Yes. So definitely it makes the treatment more cost effective because if you look at the cost of tests like CanAssist breast, which are so easily available for us now, and it is at a much economical price as compared to the Oncotype DX. So even we are doing a lot in our institution here. We are advising CanAssist breast for many of our patients who are early breast cancer patients. And if you look at the cost of the test versus cost of 4 to 6 cycles of chemotherapy, definitely the cost of testing it is much lesser. Doing the test is much lesser than giving chemotherapy. And it's not just the cost of chemotherapy per se, but definitely the patient would have hospitalizations. Many patients may have hospitalization, if not all, because of toxicity and the quality of life. The impact of chemotherapy on quality of life of a patient is something which we cannot ignore, even if it is a short term impact, even if for that 3 to 4 months the patient may be having discomfort and various problems because of chemo related toxicity. It is not something that can be ignored. And some of these drugs can have long lasting impact, can have permanent organ damage in the form of peripheral neuropathy or cardiotoxicity, which might further impair the quality of life for a longer time. So if you look at it that way, definitely we are able to salvage, or we are able to save a very big number of patients, because if you see the data where the CanAssist breast was compared with Oncotype DX, where they saw the concordance between the two tests, about 83% of the patients were in the low risk category, and about 16% or so were in the high risk category according to CanAssist breast. So, if we do not do the test and give chemotherapy to all 100 patients, then everybody would experience the toxicity. But by doing CanAssist breast and identifying about 83% of them in the low risk category, if we can avoid chemotherapy, that's a very significant number. It's a big number. 83% is a very big number. So, we are avoiding 4 cycles of chemotherapy in them, the cost associated with that, the deterioration in quality of life that's associated with that, and the hospitalizations and the supportive care that may be required to manage the chemotherapy related toxicity, the cost which goes into that, the supportive care, that's also reduced. And there are a lot of logistic issues also for many of our patients. I mean, we cannot assume that the patient is always within the city and comes for the chemotherapy from within the city, or is not next door always. We have patients in our institution coming from very remote districts in Telangana. They come to Hyderabad, traveling about 250 kilometers, 300 kilometers, they come to Hyderabad to take their chemotherapy. So the travel cost. So if you look at the cost is not just the cost of drugs, the bed charges, the doctor's fee. It's not just that. Cost is so much more. Cost is the logistics. A person has to be there with the patient, always has to accompany, has to manage toxicity at home, and has to bring back the patient in case of toxicity. And so much of supportive care might go into it. Severe myelosuppression, we may need blood transfusions, we may need platelet transfusions, we may need growth factor administration of higher antibiotics in case the patient lands up in febrile neutropenia. So all this pours into the cost of treating a patient with chemotherapy. So if we are able to save 83 patients out of every 100 with the help of CanAssist breast from the financial as well as the biological toxicity of chemotherapy, then yes, definitely it's very cost effective. And between CanAssist breast and Oncotype DX, yes, definitely CanAssist breast is much more economical, and that's the reason why it's well within the reach of a greater number of our patients. Although some of our patients cannot, they are unable to do even CanAssist breast, but at least it's a better situation, and it's a big step forward. We are able to cater to more number of early breast cancer patients with the help of CanAssist breast.
Yes, certainly it is not just about the financial toxicity. It is more about the emotional stability, the more about the support that our patients will get, and the toxicity of chemotherapy which they can avoid. Now, having looked into the clinical perspective of the oncotype, the CanAssist test. Now let us move on to Mrs. Dimple Parmar to ask what are the ethical considerations surrounding the prognostic testing.
Yeah,
Can you
sure.
just shed a light on those things?
Right. So when we talk about ethical consideration around this, what we have understood from patients, as I previously mentioned, at times the awareness is very low among the patients about what these all testings are and how it can help in saving the cost, like Dr. Mounika rightly mentioned. Because knowing in advance where chemotherapy is to be done or not, what treatment path is going to be followed, but if patients are given into an understanding of it and also explaining, doing counseling on those tests, that will be really helpful. Because at times when patients come with the prescription or anything, at times they are completely lost. That okay, we have heard from the community members or from XYZ person that chemotherapy is to be done. This is very standard, but at times based on the test, it might not be required. So patients get confused in terms of hearing from multiple people. They do their own research, they might get misguided at times from other members. So it's really important that we do the proper counseling, make them understand what it is, and also the cost that they may save when they go for the test, and how it can actually help them in planning their future also. So I remember a woman's case where she was not required to do chemotherapy because the test showed that it was not aggressive and she can actually avoid going through the chemotherapy process. And she recently got married and she wanted to conceive later. So she consulted doctor, and doctor said that we can avoid it for now, and then she can conceive the child first, and then she can go for the injections, hormonal injections for 5 years. And today the girl is very happy, she's mother. And then so for her it became life savior, and also something that it was not a big deal to go through the cancer treatment. So having that end-to-end understanding really helps. And that is why discussing about your own treatment options or how you want to lead your life post treatment, during treatment, is extremely important, and that can actually help patients and caregivers to plan it in a better way. So that will be my say on this. Hi, Rohit.
Yes, that was great comprehension. What you told is absolutely true. That most of our patients, who are especially young patients, who because of chemotherapy, they're not able to conceive, or their fertilities are affected, or all those things aspects of it. Certainly, CanAssist has because of its economic viability, it's been become a what to our patients sort of thing. So it was a great panel discussion, having actually involved with the original scientist as well, Dr. Manjari Bakre, who was one of the key founder in designing CanAssist. We have also worked with her in a lot of patients initially also, and even now, CanAssist has really initially all of us used to look towards the west for the answers. Now the west has to look towards east. We have Indian solutions for the Indian problems. We have been able to make difference in our own patients as well. So it was a great panel discussing about the progressive process in breast cancer patients. I thank all my panelists for having given their point of view and for discussing about the importance of analysis, the progressive process, and other aspects of it. My sincere thanks to Zydus and Voice of Healthcare for having provided this opportunity to discuss about such an important topic, which is very close to us, and to help us give a better patient care.
Rohit,
Over to
Rohit,
you,
we
Dr.
can't.
Nishant. Nishant, over to you.
No, no, no. We couldn't hear you properly. That's why I called her.
Can you hear me now?
Yeah, better. Go on.
Yeah. So, sorry for this thing. I was just telling that all these days it was more about we looking at towards the west for the answers, and now it is more east. The west is looking to the east for the answers. and we have the Indian solution for Indian problems. CanAssist has certainly become a great asset to our patients, and I thank all my panelists for this extensive talk and deliberations. I hand over this to Nishant to take up further things.
Hi, yes. Good evening, gentlemen, doctors. Yeah, I hope the conversation went fine. Right.
Yes.
Yes.
Yes. So,
Absolutely.
thank you to each one of you all for joining and sparing your valuable time while we discussed about the importance of breast cancer and the prognostic testing. I'd also like to thank Zydus for particularly powering this series of discussion. I'd like to thank all my panelists, Dr. Mounika, Dimple, Dr. Murali, Dr. Rohit, Dr. Ramakant, and Dr. Tanay. Thank you for joining. Thank you for stepping up and creating this campaign of awareness along with Voice of Healthcare. So have a good evening, gentlemen and ladies. Thank you.
Thank
Thank
you.
you, Dr. Nishant.
Thanks,
Thank
everyone.
you. Good night.
To all of you.
Correct.